we are going to the next step 2 of this unfolding case study, and all case studies follow this exact thing, okay? So the second one is analyze cues, and when we say analyze cues, this is more like how do we put them together? Now that we have some information about all these patients, now it's time to put them together and see where it is, what is going on. So the question is going to be based on, are you able to connect it? Are you able to put those signs and symptoms in the focus of the question and understand what's going on? Are you able to figure out the possible disease condition, the possible diagnosis, the possible issue with this patient? That's what analyzing Q is all about. You're analyzing what you got. This is where you might get more information, okay? So it says, during the initial head-to-toe assessment at the start of the shift, the nurse gathers the following information on each client. Remember, we started by getting these patients, and now the nurse is doing the assessments and she has more information, okay? So in your actual exam, this is where you have to click on those tabs because they may have more information there. So here, this is what you know. Again, it's a lot of information. I have made it into a way that it is delimited for you, like to just get the information. But in the actual exam, you may have more things there. You may have a lot of lab studies. You may get more diagnostic studies and results. So be prepared for that. Be prepared to read a lot, think a lot, okay, in your exam. Okay, client A, this is what we know now. Respiratory rate is 26, oxygen saturation is 92 in room air, lung auscultation reveals bilateral fine crackles. Now remember, client A is our chronic heart failure patient, okay, history of chronic heart failure patient. That is the client A. Okay, so their respiratory rate is a little high, but the saturation looks okay. There are crackles. It's a CHF patient. Client has +2 or 2+ pitting edema in lower extremities and reports 3-pound weight gain over past 3 days. So putting all those together, you have an idea. Okay, this is, a heart failure patient who is probably not doing the right thing. So whatever reason, it is getting more fluid accumulated, right? So that's why there is crackles, there is edema, there is weight gain, all those signs and symptoms, which is kind of contributing towards that. Blood pressure is 158/88 and heart rate is 104. So a typical CHF exacerbation patient who is admitted, right? Second one, client B. Apical pulse is irregularly regular at 96 beats per minute. All right. The radial pulse is weaker and inconsistent compared to the apical pulse. Blood pressure is 136/78. The client appears tired but is alert and oriented. The electrocardiogram monitor shows no distinct P waves and an irregular ventricular rhythm. All right. This is where we put our knowledge and our information and our thinking process together to figure out what's going on with this patient. Now, if you remember, let's go back to the first part which we had. This was a 68-year-old client who came with palpitations and sometimes feels like my heart is skipping beats. No chest pain, but shortness of breath, occasional shortness of breath with activity. So this is the client we are talking about. Now we have more information. We have the vital signs and we have the ECG. Okay, but in this question, they are not giving you the ECG tracing. We have to figure out from this, it is 96 beats, it's irregular, and there is no distinct P wave, and it's an irregular ventricular rhythm. So we have to figure out what's going on. Okay, the third patient, so this one who was having decreased appetite and night sweats. So this one says his temperature, okay, he is having fever. It's 101.8. Cardiac auscultation reveals new systolic murmur which was not there. The client has small tender lesions on the fingertips and reports joint aches. Okay, so IV drug use, had some kind of infection before because it says he was recently treated for a skin infection. He was having fever and chills. Well, obviously right now also he has fever, and he has persistent fatigue over the past 2 weeks, night sweats, decreased appetite, and what else do we know now? He has small tender lesions on the fingertips, joint aches, and he has a new systolic murmur. Okay, so client D. This is the one who had that near syncope episode, and we think that he's a really bad problem going on. We don't know what it is, but we think there is something going on. So this heart rate is 38. No wonder he was feeling, kind of dizzy and tired and was feeling like he's going to pass out when we get up because his heart rate is really low and it is irregular. Blood pressure, look at the blood pressure, 88/54. Okay, now severe hypotension, and we see the heart rate here, and client appears pale and diaphoretic, sweating. Okay, not good, right? Oxygen saturation is 90. Telemetry shows, okay, now again, we don't have the ECG with us, but they have explained to us in words how the ECG looks like, okay, the interpretation. It says it's regular P wave with fixed PR intervals and dropped QRS complexes. The client is slow to respond but remain oriented, and the capillary refill is delayed. Okay, it's not good to have a delayed capillary refill, right? That means there is some kind of issues with the circulation. All right, so look at these patients, thinking through them, making connections, trying to figure out what exactly is going on with all these patients, because analyzing cues is all that. And that's the step 2 in our unfolding case study. The second question in your unfolding case study will be analyzing cues. All right, promise you that. Okay, so this is what we need to figure out now. This can come as a drag and drop. This can come as a drop down clause. So all you have to do here is, what is client A having? What is client B having? What is client C is having? What is client D is having? You can use only one for each patient. Okay, we have 10 options here. And do we have to know all about all these disease conditions to answer this? Answer is yes. Is just the theory going to be enough? No, because we have to put them together in the context. So let's focus on just one at a time. Client A. Out of all these problems, if you can select only one thing, what is client A is having? We know it's a CHF patient. We know it's an exacerbation. We know there is crackles. We know there is edema. We know there is weight gain, 3-pound weight gain. We know that he has tachycardia and and hypertension. Yes, what is the best thing out of here which I can think about? That's going to be the 5th one. I would say client A is having fluid overload, right? That's the best option for that patient because we have all the information to tell us that this is a CHF exacerbation. So instead of fluid overload, if it was CHF exacerbation, I would have gone for that. If it said something about, acute heart failure going on, I would have selected that. So as of now, what is going to be the best fit from the options is going to be fluid overload. Now let's focus on the second one. What about client B? Now, who was our client B? Client B was the one who was having skipping beats or occasionally feeling short of breath with the activity, and we did have an ECG. and ECG says no distinct P wave. So the moment I see that there is no distinct P wave, I mean, I know how the P wave is supposed to be in the ECG, right? I know it's like supposed to be like P wave, and then we have a little Q, and then R, and then S, and then we are supposed to have a T, you know. Sorry. So this P wave is not there. We don't have any distinct P wave. So if there is no P wave, if the ECG, the P is like that, that is AFib. Now, can somebody with AFib have 96 beats per minute? And the answer is yes. Now, how do we know it's irregular? There is another point here which they have suggested to us to let us know it's irregular. It says irregular beats, and this is radial pulse. Okay, when I said the radial pulse, it's weaker and inconsistent compared to the apical rate. Now, the apical rate, we know we have to use the stethoscope and we put it in the mitral area and we listen to the heartbeats. So that's how we get the apical heart rate, like for 1 minute. But whenever I am taking the radial pulse rate, you know, because it is irregular, I'm not getting everything here. Okay, so this is where we know it's an AFib. So what's going to be the best option for client B now? Client B, I would say this one is, where is it? Okay, atrial fibrillation. Okay, so client B is possibly having atrial fibrillation. All right, let's go to client C. Let's see what can happen to a patient who is IV drug abuse patient, you know, and we know there is an infection, you know, there is an infection. How do we know that? Because he is having fever, he is having sweating, he is having decreased appetite. So we know it's an infection. So I don't think it's iron deficiency anemia. Now, I'm thinking about valvular heart disease, maybe. I'm thinking about rheumatoid arthritis because he said there is joint pain and stuff. And yes, I'm thinking about infective endocarditis. I don't think it's pericardial effusion, because if it is pericardial effusion, he will have chest pain and he will have a lot of shortness of breath, which was not there, right? So I don't think it's that. We already took out fluid overload. We already took out atrial fibrillation, and it's not sinus bradycardia. We know the heart rate and stuff, right? So it's more like towards this. So let's see. There are a couple of things which are very, very specific here towards infective carditis. Okay, fever is one, but fever can be also in other things. Yes, new murmur. It says there is a new systolic murmur. Okay, that's one. Now, when there is a new murmur, I think I can avoid rheumatoid arthritis and more towards valvular heart disease or infective endocarditis. In those two cases, we can still have a new murmur. So now I am between, like, is it valvular heart disease or is it infective endocarditis? But valvular heart disease may not have fever all the time. But this guy has fever. So I'm still going towards infective endocarditis. Also, there are tender lesions on the fingertip. That is very, very important to remember. Now, we talked about it in cardiac lesson. In endocarditis, we talked about it. Patients will have fever, there can be new heart murmur, and there can be painful nodes, right? And we talked about all these oscillus nodes and these issues which are very, very specific to endocarditis. We discussed this in cardiac, okay? So in case you are not familiar with this, once you get into the cardiac lesson, you will learn all about this, I promise. Okay, so that's where we are kind of, it says painful nodes. And when they say it's like tender lesions, tenderness means painful. So when you touch, it's painful. So we have all the data now to say that this is infective endocarditis. Now the next one, the client D. The heart rate is 38, blood pressure is 88/54. Client is really not stable, hemodynamically not that stable, appears pale, diaphoretic. Okay, there is an ECG. What is this ECG? P wave is regular. PR interval is fixed. But there is dropped QRS complexes. Okay, this is heart block. Okay, this is second degree type 2, morbid 2. There are regular P waves, PR intervals are the same, but there is dropped QRS. Okay, and because of that dropped QRS, that's why their heart rate is so low, right? It was 38. And he is not hemodynamically stable. He's 88 by 54, severe hypotension, symptomatic, right? This is really bad. And capillary refill is delayed. This is decreased cardiac output, conduction delay, not good. Now, this is not sinus bradycardia. I know there is a sinus bradycardia here. This is not sinus bradycardia. Don't go for that just because the heart rate is 38, because we know there is dropped QRS. In sinus bradycardia, there is no dropped QRS. It's just everything will be there, but it's just slow, right? But this is not that. This is more problematic than that. So, what is going to be our answers in this one? Okay,